I'm recording now. Okay, so let's finish up transfusion. Okay, so I think this is chapter 16. You can see my textbook, right?
Yes.
Yes, I can see it.
All right. Let's start with page 294. Under infusion therapy. Okay. All right, IV therapy. So there's a QSEN question here about delegation. All right. So you get a delegation question. Here are your answers. So the RN, if you look at between RNs, LPNs, and UAPs, RN's job is always EAT, so education, assessment, and teaching. You can delegate any task like a procedure to a LPN. However, that must be on a stable patient. So it tells you here, LPNs can administer IV fluids to stable patients, right? So unstable patients are of course newly admitted patients, or even if they are existing patients on the floor, their condition must be the same. Whenever the patient's condition changes, then are they still stable?
No.
Okay, so there's a change now, so the RN has to do it. But moving forward, then as long as the patient's condition did not change, then the LPN can do the task. Okay, see, they can even insert IV catheters. Okay, meaning they can start IV access. However, these must be on stable patients. Okay. All right, so we did peripheral IV therapy under the IV skills module. IV therapy, if not last week, it was a couple weeks ago when we did the ATI. You still remember that? Under IV therapy. Okay, so this is now central venous devices. So we have two types of central catheters. We have tunneled and non-tunneled. Oh, by the way, there are three main types of central venous access. They're called central venous because unlike peripheral IVs that you start on a peripheral vein, let's say the cephalic, basilic, cubital veins, peripheral smaller veins, these are inserted in large veins. So the two commonly used vessels are the subclavian and the jugular, internal jugular vein. Sorry about that. So we have two main vessels being used, the subclavian and the internal jugular. So we have three main types. We have the central line. There are two types. We have a tunneled and a non-tunneled. I'll explain the difference between the two shortly. We have Picc lines, which are inserted by nurses. And that's pretty much the only central line inserted by nurses. Central lines, the tunneled and non-tunneled, are inserted by doctors and advanced practitioners. Ports are also only inserted by doctors. All right, so why would people need central lines? All right, so these are the um, reasons here. I won't read the whole thing. Um, Other reasons for a central line is long-term venous access. This one, you need something for a long time. Or if the patient has poor peripheral venous access or limited peripheral venous access. So what can you use for a central line? First of all, you can use it for any infusion that you use a peripheral line for and more. So central lines allow you to give rapid, large amounts of fluids and medications. So let's say you have a critically ill patient with severe burns, for instance, or in shock, wherein we're giving 1,500 to 2,000 mLs of fluid per hour, right? So you need a large vein for that one. That you can't, it's just impossible to infuse through a small vessel. Okay, so we have Kevin now and McCrane. And who is this iPhone?
iPhone, that's probably me, Professor. That's Troy.
I saw your, no, it just says, I see you. It appears as Mr. Simmons' cellular device, but there's somebody.
Oh, yeah, that's me. That's me.
Who's the iPhone? It's still you?
No, that's not me. I'm Mr. Simmons Cellular.
Is this Marcia? Marcia here? No. How about Sandra? No. And Maria? Okay.
Hi, it's Sandra. Just I was having audio problems.
Okay. All right. Thank you. Okay, you have the complete list here. Table 15. That these are the complete list for a central line. So people mainly with cancer, they'll use the central line for chemo. You'll use it for long-term antibiotics. If you remember if you've already read the material under heart failure, the same chapter talked about endocarditis. If you come across that, how long is the therapy, IV antibiotic therapy for endocarditis patients? Have you read that part yet?
No, I haven't read that part yet.
Okay, so the IV therapy there is typically 4 to 6 weeks of IV antibiotics. So you can't use a peripheral line for that. So this would be one of the indications. So the patient will need a central line, either a central or a Picc line, not usually a implanted port. Okay, so we'll discuss implanted ports shortly. So these are the indications. Some people with chronic pain will require, typically these people will require an implanted port. Okay. And if the drug being infused are the following, okay, they are known to be very caustic, typically causing phlebitis, so it's better off given through a central line. And these are some of the other indications, although you can infuse blood through a peripheral line, but like I said, anything you can use on a peripheral line, you can infuse through a central line. Hemodynamic monitoring. So these are really sick patients. So you'll need a central line not only to measure central venous pressure, although this is a different type of central line they are mentioning here. We are monitoring hemodynamic measurements using a peripheral, no, not a peripheral, but a pulmonary artery catheter. All right, so let's discuss each one because the questions on the exam will typically be your management nursing management over central lines. What do you do? What do you assess? What education do you provide the patients? What are the common complications on these central lines, and how do you recognize them? And more importantly, what do you do? Okay. So central catheters are illustrated here. So this figure 16, 18, this one though is a tunneled one. Okay. So again, there are two types of central catheters. A non-tunneled one is shorter. So it's about from here to here. Okay, so it's about maybe 6-8 inches long. So it's short. Non-tunneled can be inserted at the bedside. A physician can do it at the bedside. The most common complication associated with this will be so let's say this is the chest wall. This is the patient's neck. Okay, nose. Okay, all right. So let's say this is the patient's mouth. Okay. So this is the chest wall. So imagine this is the nipple right here. So the subclavian is somewhere here. So the layers of the skin is, let's say that's the dermis, just exaggerated, that is that thick. And then this, of course, is the subcutaneous layer. Okay, so this is the dermis. This is the subcutaneous layer. And then we have a thin fascia there. And then finally the muscle. Okay, this is now the muscle. Then underneath that muscle is, of course, your pleura. Okay, so you have the pleura encompassing your lung. So this is now your lung with a pleura. So of course, I'm exaggerating the thickness here. It won't be this thick because if you feel your chest, okay, go ahead, everybody, feel your chest. Can you feel your ribs through that when you palpate your chest?
You can feel your ribs.
Easy to palpate the ribs. It's easy, right? Okay, so
Yes, it's easy. I can feel it right now.
Yeah, so is it really thick pad of tissue there? Because when the doctor inserts the subclavian, of course the doctor has knowledge of anatomy of where the subclavian will lie. However, he's going in blindly. So as he is fishing for the subclavian vein, there's a tendency that he may at one point may have inserted the needle too deep and has punctured the pleura. Okay, so while fishing for the subclavian vein, he may inadvertently, accidentally poke too deep and reach the pleura. So when he does so, now there's a hole in the pleura. So there could be a pneumothorax that will form there during this procedure. Okay, so that's one of the complications of putting a non-tunneled catheter, which is very common. That's why a protocol right after a central line insertion is the patient will be sent for X-ray, chest X-ray, to do two things. One is to confirm where is the tip of the catheter lying. The second is to identify whether or not the doctor caused an accidental pneumothorax. Okay? And then depending on the size of the pneumothorax will determine the treatment, whether the patient will just be given oxygen or if the pneumothorax is really serious that they'll require a chest tube. Okay, but it's quite rare. A non-tunnel catheter, which is not mentioned here, they just called it a Hickman. A Hickman is a tunneled catheter. It is surgically implanted, meaning it can't be done at the bedside. This has to be done in the operating room. Look at the picture of a tunneled catheter. So there are two incisions here, one here, one here. Again, there are two incisions made, one here, one here. So the catheter is tunneled under the skin. So from this section here, let me nip this thing. A snip. Okay. So from this number 1 here, this is the first incision. This is now the second incision. So they will tunnel the catheter underneath here. So you can feel this. So when you palpate the patient's skin, this length of this part of the catheter can be felt under the skin because this is right under the subcutaneous tissue. Okay, so this is what we call the subcutaneous tunnel. The catheter didn't really enter the vein. This time, this is the subclavian. Okay, so it didn't enter the subclavian vein until right here. Okay, so what's the purpose of tunneling? Well, this will make the catheter pretty much in there indefinitely, okay, as long as it's not infected. It is also less likely to be infected because you cannot see the insertion site. The insertion site, what I'm talking about, the insertion site is the vein entry. Okay, the vein entry can't be seen. So there is no infection. If anything gets infected, it's really this insertion right here, which can be local. Okay, so this is the main insertion site that is visible. The rest of it is invisible. So therefore, it's less likely to get infected, making this catheter now a long-term type of central line. There's really no set period of time that it's in there. I've looked at textbooks. There's really no set recommendation as to how long it can be in there. So the answer would be as long as it's not infected, so it can stay there. Okay, so it becomes a long-term access if it remains infection-free. Okay, so that's the reason for tunneling a catheter. So why would physicians insert a non-tunnel versus a tunnel? It really depends on the need, as I mentioned earlier. What does the patient need the central line for? Okay, so if they need it for a short period of time, then they will benefit from a non-tunnel central line. Plus, it's readily inserted at the bedside anytime they can insert it. No pre-op preparation because it's not done in the operating room. Tunnel catheter, however, is long-term and it can only be done in the open. Welcome. Any questions so far?
No.
Okay, so clear with non-tunneled and tunneled catheters?
Yes.
Okay, again, these are for a tunneled catheter is for long-term. Non-tunneled catheters, another the reason they don't last long is it can easily be pulled. So you have a confused patient, pulls this thing if it's a non-tunneled catheter because it's short and it's only secured by 2 tiny sutures. So a confused patient can easily rip that off, pull it out. Just like a peripheral line, okay, it can easily be pulled. A tunneled catheter, however, isn't so easy to pull. So let's say the patient is confused and tries to pull this thing. It will cause considerable amount of pain because of how it's put in. I mean, if they try to grab this, they'll probably stop halfway because of the pain. Okay, just imagine ripping something underneath. Okay, so they'll probably try to pull it, just because they're curious, they're confused. And what is this? They try to pull, and because it causes pain, they'll stop. All right. They come in different lumens. I've never actually seen a central line with a single lumen. Plus, it would be very counterproductive. It's useless if it's a single lumen. When we say multiple lumen, is if we cut a catheter. So let's say this is the cross section of the catheter. It's not going to be like a regular IV catheter wherein you have one lumen. Okay, so if it's a multiple lumen, meaning that the catheter is thicker and it will have multiple, 3, 4, sometimes 5 different lumens. Okay, meaning it's like having 2 to 5 catheters in one. So they also do not mix because obviously the medication infuses in each of these lumens. So you have 1, 2, 3, 4, 5. So you can infuse 5 incompatible solutions into one central line. Does that make sense? Because they never mix. So at the end of the catheter, here, they also come out in different, so each of these lumens here, these 5 lumens come out at different holes, okay? So because there are 2 to 5 catheters inside one catheter, so think of it as a cable, a wire cable where you can have multiple lines inside one bunch of cable. So they technically do not mix. So there's separate lines in here and they come out in different exits. Although, of course, they mix when they enter the bloodstream, but if there are interactions, yeah, interactions will still happen. But fluids, as far as whether or not they're incompatible in the same line, we don't have that problem because technically we have multiple lines in that central line, in that central catheter. Questions, violent reactions? Are you still with me?
Yes.
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 All right, moving.
Yes.
So we have, all right, I already mentioned that Picc lines can be inserted by nurses. Okay, so you will be working under radiology department. You are a special procedures nurse, and this is what you do all day. So you are inserting Picc lines. This is done, of course, just like the central line, which is under sterile conditions. So you'll drape the patient, put in sterile drapes, and then sterile gloves, and you insert this though under ultrasound guidance, okay? So you will insert this through a peripheral line. So hence the name, peripherally inserted central catheter. Because the catheter is inserted in a peripheral vein. So these are the cephalic or basilic or the cubital veins, which are peripheral, smaller veins. However, it's very long. This thing can be as long as 18 to 20 something inches, depending on the patient's height. Okay, so it's inserted here, usually in the basilic vein, or sometimes the cephalic, or the cubital. Okay, the cubital vein here also is another site. Regardless, it's very long. Okay, so it stops right about here. Now, how does the nurse know when to stop? Well, that's where the fluoroscopy comes in. So we need X-ray confirmation. So unlike a central catheter, a central line, look at where it ends. It ends right above the end of the superior vena cava. It doesn't really enter the right atrium. The Picc line is in the same section. Okay, so we will need X-ray confirmation, just like a central line. We get an X-ray after insertion to do what 2 things again? Why does a patient after central line, central catheter insertion need an X-ray?
So we know where the tip of the catheter is?
And what is
To rule out a pneumothorax?
Very good. Okay, so 2 things, right? To determine placement and also to check if the doctor caused a pneumothorax. For a Picc line, there's only one purpose for the, because does this cause a pneumothorax?
Possibly.
If you say yes, possibly, how though? I mean, you inserted it here and then you threaded it through the vein up into the end of the superior vena cava. You never poked a needle anywhere in the thorax. So can this cause a pneumothorax?
No.
No. Okay.
No.
However, because you inserted it in a peripheral vein, look at the size of this catheter. Okay, a big catheter inserted through a smaller vein. What could be a possible complication here? What can form on this peripheral vein? Which is a very common complication for Picc line.
Is it an embolism?
A thromboembolism. Very good. So a blood clot will form. Okay, so that's why your responsibility for Picc lines is to do what? You should measure what every day or every shift actually.
Extremities.
Okay, you will assess, actually take measurements of the circumference of this arm. So we will measure right at the insertion site. So the whole arm here will be measured right after insertion and every shift thereafter. So we always compare it with the other arm to see if there is any increase. So an increase in the arm diameter here will increase that there is swelling. That means there is a blood clot in there. All right. So here, it usually happens within 7 to 10 days after insertion. To avoid though the formation of a blood clot, although we really can't stop it, but we can decrease the likelihood by not using that arm for blood pressure reading. Here is the rationale for that, because when you inflate the cuff, it will cause the Picc line to touch the vein wall, causing the increased likelihood of a blood clot. The complete complications of central venous access devices, whether central line or a Picc line, are the following in table 16-19. So it can be occluded. These are your, how do you know it's occluded? Here, you can't, it's hard to flush the line. It's hard to get a blood return. And these are your management. These are your actions. So before you try to troubleshoot first, tell the patient to change position, do the following, right? Or ask the doctor for X-ray, or fluoroscopy is X-ray. Okay, or the doctor may order you to put in a anticoagulant, heparin, or a tiny bit of alteplase, okay, a thrombolytic agent. Embolism, as already mentioned, so these are your, meaning the blood clot already traveled, so it's either a PE or worse, a stroke maybe, hopefully not. If it is a PE, then we manage a patient with a PE. This is the most, one of the most serious and also usually catheter related is infection. So it's either called catheter related infection or catheter related bloodstream infection, or that's collapse, or central line associated bloodstream infection. So it comes in many names, but it's the same thing. The central line is already infected. Always starts local. Okay, so these are your signs. Remove catheter and your doctor will order you to cut the tip and send it for culture to identify the growing organism. Hopefully it's only local. Okay, if it's systemic, then that's a more serious problem. Patient could go septic. Here's the pneumothorax. Again, if it's small, we simply give oxygen, just have the patient, deep breathing, and the body will eventually eat the air that is in there. Sometimes it's also absorbed. If not, if it's really large, then we'll need a chest tube. Catheter migration, these are the causes. Somebody did not secure it properly. Remember when we did the IV therapy on ATI last week or 2 weeks ago? What did we use to secure the central line or the peripheral line? What was that device used to keep it from moving? You guys still remember? No, I introduced it as a device that will extend the life of a peripheral line from 72 hours to 96 hours. What did we call that piece of adhesive? Are you still here, guys? So that was called a stat lock. Yeah, remember? Okay.
Yeah, we're still here.
Okay. So this is the last type of central line, an implanted infuser port. So this is surgically implanted either on the arm or on the chest. So the entry is either the cephalic or usually the basilic, if it's inserted in the arm, which is rare. Most people with infuser ports, their ports are on their chest, either the right or left upper chest. Most frequent is the right because they avoid the left in case the patient develops, a sick sinus syndrome or heart blocks. Then they might require a pacemaker, and so they'll try to reserve the left upper chest for a pacemaker. So they'll typically put in the port on the right upper chest. So the port acts as an extension of the vein. So it's put under the subcutaneous layer right above the muscle. And this will be the reservoir. So it's made of titanium here, titanium or plastic. It has a self-sealing silicone septum. So this is what you hit every time. So this is surgically implanted. This is again the extension. So think of it as an extension of the central vein, meaning every time we access this thing, we are not hitting the vein, but rather the reservoir, which is the extension of the central vein. So here is the reservoir, and this is how it's implanted into the central vein. So this could be the subclavian, or this could be the basilic vein. Okay, so whichever one. Again, the most common site is in the upper chest, so typically it's in the subclavian. So what you access really is just the reservoir. Okay, so you will feel this thing underneath the skin. It's impossible to miss. Oh, you know what? I shouldn't say that because I have seen nurses who miss it. But it's, again, it's impossible to miss because this is a sterile procedure when you access this thing. So the doctor already implanted this, right? So the patient has it. Open a central line kit. You have sterile gloves on. So you put antiseptic on about 4 inches wide, okay, around the insertion site. Then you hold this thing steady, and then you insert the needle. The needle used is called the Huber, although this is not the only brand. There are different brands there, but the Huber is the most commonly used needle. So it's a bent needle, okay? Sometimes it's also straight like this, but vertical like this. However, the tip is always curved. This will prevent you from damaging the base, okay? But I think it's impossible to pierce through this thing because this is either titanium or plastic, okay? Unless you stab it with a knife, maybe, yeah, you'll damage it. But as long as you use a needle, it's impossible to poke through this thing. So you insert the needle, and the needle is covered with a 4x6 or 4x4 tegaderm, and there's your IV access. And then we also have a extension tubing, just like a peripheral IV catheter, okay, and that's what you access. So the needle stays in for the whole duration of the patient's stay, but the infuser port is there forever. All right, I've seen patients like the last patient I took care of, who had it. His name was Holderbaum. That was his last name. He had it in his arm. So he died still having the infusion port. Okay, so he's probably ashes now, but I'm sure his infusion port is still there. So this thing, the septum can withstand anywhere between 750 to 1,000 needle sticks. Okay, so that's how long lasting these things are, right? So again, it's not like you poke it every day. You only, so the patient comes in, they're admitted, they have an infusion port, you stick one Huber needle in it, and the Huber needle stays for the entire hospital admission. Or if it's outpatient, then the patient keeps the Huber needle on there for the duration of their treatment, whether it's for, I don't know, 6-8 weeks of chemo or whatever they're using it for. We only remove the needle, or we call that deaccess the needle, once the therapy is finished. Any questions about an implanted infusion port? Okay, so silence means no. All right, so with any central line, there are of course complications. This thing is a foreign object, so it will always be a threat. It will always be a potential source of infection. So you need to watch, monitor it, especially if you're accessing it. If it's an infusion port, every time you access must be a sterile technique. Okay, and you already know local signs of infection. So they are local signs of inflammation following edema, warmth, there's drainage, or the site feels tender. Okay, so I already mentioned that we need x-ray, right? What I didn't mention is you cannot use the central line until you verify placement. All right. Although we can verify also using a blood return, meaning you aspirate for blood, that means it's in there. But if it has just been inserted, meaning newly placed, just inserted today, you need an initial x-ray verification. For succeeding checks, meaning moving forward, let's say tonight or tomorrow and onward, of course, we don't need an x-ray because we already confirmed x-ray placement, initial x-ray placement already. So therefore, you just verify placement routinely using the checking for blood return. All right, so this is a given. You always wash your hands for obvious reasons. You don't want this thing to be contaminated. We always scrub the clay port before we insert any syringe into it. Okay, dressings. Okay, so question on exam will be dressings because you are the one changing the dressing. All right, so what types of dressings do we use? Number one, strict technique, sterile technique, of course. We use a transparent dressing or gauze and tape. Now, the gauze underneath the transparent dressing is only used on the day of insertion because some bleeding is expected, just like here. If there's bleeding underneath, which happens on the day of insertion, yes, we put gauze in there. That was a sterile gauze. However, does the gauze stay sterile? Yes, no, maybe?
No, it doesn't.
No, because when you put in a sterile gauze in there and then covered it with a sterile transparent dressing, yes, it was sterile when you put it on that day. But the moment that gauze starts absorbing blood, or any other fluid, what is glowing in that piece of gauze, which you covered with a waterproof transparent dressing?
What's growing, you said? Microorganisms.
All right, because can you sterilize the skin? Can we sterilize our skin?
Yes.
How?
Well, not directly. I mean, we still have our normal microbiota that is and needs to be on our skin to fight bacteria, but
Okay,
we can sterilize it
yes or no?
temporarily.
Can you think of any antiseptic that says kills 100% of germs?
No, you're right. No.
Yeah, so it's impossible to sterilize living tissue. Yeah, probably you can sterilize a dead person's body. We can put them in an autoclave. Yes, that will be 100% sterile, but the patient is already dead, right? So you will also kill tissue if you sterilize it using an autoclave machine. So the answer again is it's impossible to sterilize the skin. So that's why if there's a gauze dressing underneath there, that gauze can't stay more than 2 days. So it has to be changed every 48 hours if there is a gauze underneath that dressing. But it's not mentioned here, but our protocol is if it is inserted today, which the doctor or whoever inserted it will put a gauze because it's expected to bleed because you had just put it in today. You have to change it the next day. Okay, so again, if the initial dressing after the insertion is today, it has to be changed tomorrow. But whoever changes it tomorrow, so let's say they decide to use gauze again because they saw, oh, there's still some bleeding, tiny bit of bleeding. I'll put another piece of sterile gauze in there. When should that dressing containing gauze be changed again?
The next day?
That one can be 2 days, up to 48 hours. However, look at this. Thank you for reading, Troy.
Yeah. Transparent dressing may be left in place for up to 1 week.
All right. So if you're a smart mouse, what type of dressing should you use?
Transparent.
Transparent.
Transparent dressing only. Do not put gauze there unless you have to. All right. Everything clear with dressings? Because this will be asked, because this is something you do whenever you have a central line, whether it's a Picc line, an infuse support, whatever central line, it has to be changed. Did we change dressings in a peripheral IV catheter last week? Did we ever talk about changing the dressing?
No, I don't think we did.
No, because it was only for 3 days, right? Plus, did we put gauze underneath it in a peripheral line? No, there was no gauze, right? It was just a transparent dressing. However, if any dressing, peripheral line or central line, becomes soiled, damp, or loose, we should change it immediately. Clear, ladies and gentlemen?
Yes.
So
right.
far.
Okay, so the central line dressing kit is standard everywhere, whichever country. The kit remains the same, whether they're from China or from America, which everything nowadays seems to come from China. I don't know if that will be changing soon, because we just learned our lesson with this crisis that over-dependence on other countries for our medical equipment cripples us, right?
Yep, including coronavirus.
Exactly. So central line kits will probably start to be manufactured locally now or domestically. The standard antiseptic use is chlorhexidine. I have not seen a kit that uses isopropyl alcohol anymore, nor did I see anything containing betadine. So the standard nowadays is chlorhexidine. I think it's 2% chlorhexidine. So this thing can kill anything, even MRSA, MRSA. This thing can kill it. I don't really know which organism it can't kill. Okay. However, when you rub this thing on the insertion site, there has to be friction. Okay, so don't just wipe it like you're wiping your face, putting on makeup. It's not like that. You have to use friction. You have to remove debris. Okay, because the whole time that the patient had it there, bacteria don't stop growing. So you have to remove debris that is not visible in the with the naked eye, and then we allow it to dry, of course, air dry. Do not blow on it, and then you apply a new dressing afterwards. Okay. And our standard is we always our saying is scrub the hub. Okay, so we scrub, like really scrub. Okay, the hub is referring, I'm referring to the port that into which you attach your needle, I mean your syringe rather. Do you understand what I'm saying? What I'm referring to? The this one. Do you see the picture?
Yes.
Okay, so these are the needleless ports. Okay, so you have to scrub these suckers. Okay, so you have to really scrub them really well before you connect anything to it. Okay, whether it's an IV tubing or your needleless syringes. Okay, so they have to be scrubbed really well. All right. All right, flushing. So what syringe do we use? How much fluid do we flush them with? Because this is, again, your day-to-day maintenance. All right, so flushing is not only used to maintain patency, but also to make sure the line stays patent, because you don't want to keep drugs in the line. Okay, so all the drugs must enter the patient. Now the size should be 10 ml. You should not use a smaller syringe. Okay, doing so will apply so much force, okay, that it will damage the catheter. So the recommended size of the syringe is a minimum 10. 12 ml is also fine. Okay, so there should be a minimum 10 ml size syringe, or 12. Okay, 10 or more. So that's 10 or 12. I wouldn't recommend a 60 syringe also, because that's, first of all, it's very hard to use. Okay, it's impossible to push. So 10 or 12 is great. Again, this is the right size to avoid excess pressure. Okay, again, the catheter will be damaged if you use a small syringe. It may sound impossible, but not really. Think of it as if you put a tiny syringe to it, is it hard or easy to flush the line if you use a small 3 ml syringe?
It's tough.
It's very easy, right? So therefore, how much is the pressure that you are generating when you do so? A really high pressure, right? A really high amount of pressure. So therefore, to avoid that, you should only use a 10 or 12 ml size syringe. If you feel resistance, do not force it. Again, you might damage the catheter. The catheter tip might rupture, and they could become emboli. Okay, so you'll have pieces of plastic circulating through the patient's bloodstream. All right. Okay, so let's do the technique. So how exactly do we flush? All right, so we use a push pause technique. So we have a 10 or 12 ml syringe filled with saline, right? So how we flush this is about 5 mLs per second. So if you have a 10 ml syringe, you will push that syringe only twice. So you go really fast. Unlike a peripheral line wherein you baby that thing, you flush that thing really slow. This one you have to flush really fast. Okay, using a rate of about 5 ml per second. So you pushed a 10 ml flush containing saline twice. So you push, pause, push, pause. All right, so that's what we call push pause technique. So that will enable you to remove debris that have stuck to the catheter lumen. Right, any questions so far? So that's how you flush it. Or 1 to 2 ml is also okay, but you want it really faster pressure, so about 5 ml is good. Okay, can we remove central lines? If the patient can pull it, why not we, right? I mean, we have confused patients pulling IV catheters all the time. So yes, nurses can also pull it, except tunneled catheters. So here, we can only pull what type of central lines?
Non-tunneled.
Okay, Picc lines and non-tunneled, because the non-tunneled are shorter, right? The tunneled catheters must only be pulled by a physician because it's tunneled under the skin. So well, personally, our liability insurance doesn't cover us if something goes wrong while pulling that thing, so leave it to the doctors. And of course, it's a large catheter, so you should apply at least about 5 to 10 minutes of pressure on the site, unlike a peripheral line wherein you probably just apply 2 to 5 minutes of pressure and then it stops bleeding. This one is quite large, so you have to apply at least 10 minutes of, apply pressure for at least 10 minutes. So we did central line dressings, flushing. Any questions, guys? For central line, so that covers IV therapy. The important thing again is the complication. One. This is table 1619. Okay. So most important is to recognize what does it look like when these things occur. So that's column number 2. And then the other half is what do you do? Because you can't just say, oh, I knew it was catheter occlusion. High five. Let's get out of here. You are expected to provide interventions, right? What do you do once you discover the complication? So you need to know actually all 3, because this one, the cause, if you know the cause, then can you prevent it? Yeah, okay.
Yeah.
So I would say all 3, because you need to know the cause, that way you know how to prevent it in the first place. You'll see this in most hospital floors. Hospital Press Ganey reports show this as CRBSI, catheter-related bloodstream infections. So have you ever attended the daily briefings in the nurses station wherein the whole nursing team together with either the charge nurse or the nurse manager do a powwow, usually either at the start of the shift or around 10-11 a.m.?
No.
If you do, whenever we get back to the hospitals, you'll see the briefings. One of the things they always ask is who has Foley catheters, who has central lines. Why? Why do they have to ask about these things?
Risk for infection.
All right, again, these are potential sources of infection. So the question you should ask every time you have a patient who has either a Foley or a central line specifically, you should ask yourself, does the patient need this? Okay, why is it there? If at any time your answer is no, or I don't know, then you should question it, right? Meaning having a central line, there has to be a purpose. Why is it in there? If it's not being used, should it stay in there?
No.
No, there's no reason for it, then it shouldn't be there. All right. Remember, you're responsible because you can't just say, oh, the doctor ordered it. He'll be responsible. But when it comes to lawsuits, let's say this patient dies because of a central line infection. So the family decides to sue. You are part of the team who took care of that patient. So therefore, you agreed that the patient should have that catheter in there. All right. So every time you have a complaint, or let's say you disagree, what should you do? Let's say you had a protest.
Write it in your nurse notes.
All right, very
Document.
good. Always protect your.
Yes. I mean self.
Okay, I didn't say that. You did. Alrighty. Let's go to infusions and then we'll call it a night. Everyone ready for next week's exam?
No.
Come on.
Heading there.
We're ready. We're ready to take it, but we're not ready. We're ready to see a good grade, basically.
Alright. Regarding that, so what are you doing about the getting a good grade? How do you ensure that?
Well, firstly, definitely the base is just reading the material. That's just the base. Then after that, you definitely got to practice questions because, these questions hit you with a curveball. You just want to get your mind right, put yourself in that mind frame of how you should be answering the questions because, you could read the material, understand the material, but you don't know how to apply it in those questions.
Exactly.
Right, so what I always say is you find out what you don't know, right? And the only way you discover what you don't know is through practice questions.
Cardiac is really complex,
Professor, you got any? Go ahead.
No, I was saying cardiac is really complex because when you like read the book and everything and you're going over the material, the answer choices are so close to each other, so you have to like think about the priority, which one is the priority first. And sometimes you chose that one and that's not really the right answer according to the rationale. So it's full of complex like that.
Okay. So what are you doing about that? There
Yeah.
has to be a way to do
Professor,
that.
you got any tips? You have any tips? Like,
Well, what I did,
Professor, you got any tips like to study wise?
yeah, so how I studied it is, let me show you. When I came into this country, I had $500 on me, and I have to pay rent, buy food with that $500. So I don't have funds to buy, Kaplan resources. So Kaplan has a channel. Okay, so Kaplan has the Kaplan channel. It's MCAT. Try and click. I'll try to download and save the video. For now, let me show you. Okay. So this is what I used when I studied for the NCLEX. I watched these 4 videos. One is select all that apply, how to eliminate choices, prioritization questions, Sia mentioned, and then other test taking strategies. Okay. So they have suggestions here. The only thing here is you watch the video a couple times. These are short. They are because these are from webinars, so the webinars run in about 50 minutes, so they're less than an hour each. The important part of this is to apply their techniques. The point is to practice questions before the test, right? So you don't want to practice during the test.
Yeah.
Do your practice, apply strategy, the prioritization type. So you use time wisely. You do your practice questions.
My signal is bad.
Yeah, always during the practice. Okay, always before the exam. All right, I'll try to download these and then see if I can upload it on Blackboard. Okay, if not, I'll just send you the link if I can. You might write it down. Okay, so let's review again our infusion. So the nurses part of this is again your nursing responsibilities. So questions might be on, this is chapter 30. Okay. All right. You know about Jehovah's Witness, right?
Yeah, blood transfusions. They won't get it. They won't get it.
Very good. So let's say you receive an order. Doctor writes type and cross, or no, type and screen. Say you have a pre-op patient. Writes, okay, consent for, I don't know, appendectomy. And then type and screen, 2 units. Type and screen. What does type and screen mean?
Determine the PDO and then
Will the blood bank thaw any blood?
no.
No. Type and screen is simply determining the patient's blood type and then screening them. Okay, there is no cross match here. Once the doctor writes cross match, then the blood bank will thaw a blood bag and then cross match it against the patient. Doesn't mean the patient will need that blood, but we have already thawed it and it will be cross matched. So if the patient needs it, then it's ready. All right. And then you also need a separate order to transfuse. Doesn't mean you're going to infuse the blood. All right. So there has to be a separate order to actually transfuse the blood. These are the indications for your blood products. We have packed red blood cells. These are the indications. You have frozen RBCs. These are usually for auto transfusion, meaning the patient, let's say, has an elective surgery. They plan to have a knee replacement in July. So they'll bank their blood usually 3 months before the surgery, because it takes us about 2-3 months to replenish our blood. That's why if you're donating blood, you can't donate blood in less than that time. Okay, there has to be a certain time period before you can donate again, because they're estimating that the time that you're able to replenish your red blood cells that you have just donated. Platelets do not last long. They unlike red blood cells, when you have 120 days, these things only live about a week, okay, 7 to 10 days, and then they're dead. These are the indications. We do not transfuse platelets routinely. The patient must be really thrombocytopenic, let's say below 10,000 before you can transfuse it. Exactly for the reason that they don't last long anyway. So it'll be a waste if you transfuse it unless it's really necessary. Plus it takes a long time to donate, so you don't have a lot of platelet donors out there. Fresh frozen plasma is indicated for, again, bleeding disorders, specifically if they lack clotting factors. This will also be used if the patient has DIC or has an overdose of warfarin, meaning the patient took too much Coumadin and their INR is through the roof. Vitamin K won't stop the bleeding anymore, so they need plasma because plasma contains clotting factors. Then you have albumin, which is given in either patients with liver cirrhosis or in shock or patients after dialysis. Okay, so albumin is mostly water, but it's rich in protein. Okay, so albumin. So this is what if you need to give a patient, you need to expand the patient's blood volume quickly. So albumin will be very useful. And cryoprecipitate, usually for bleeding disorders like hemophilia. Okay, these are specific. The procedure. So you get an order to type screen, cross-match, and then transfuse. So what do you do next? So you have a transfusion order. What should you do before proceeding with this procedure?
Informed consent.
All right. Go talk to the patient and give them the consent form to sign. Of course, the doctor should have explained the procedure already. All you're doing is obtaining the signature. So they signed, that means they gave consent, officially gave consent. So you get your, you proceed with the order. So depending on your unit, whether you draw the blood sample yourself or have a phlebotomist come up to draw the blood sample for typing, crossing, and screening. If not, then you do it yourself. You can prime the line while the blood is being thawed and being cross-matched. So you can set up your pump, your tubing, and use only saline. Okay? No other solution, no dextrose, no LR, only saline. So you set it up and determine what type the patient should be, what should they receive. So this could be a rectal apply question or simply a multiple choice. Okay? What blood products can you safely give to the patient? And did we discuss the RH negative already? If a patient is RH negative? No?
Mm-hmm.
No? Okay. All right. So the problem comes if you have a patient who is RH negative. If they're positive, we do not worry. It's really the RH negative patients that are critical because you cannot give them any RH positive blood simply because they will react to it, and that reaction is usually fatal. However, upon first exposure though, let's say this is the first time I am RH negative and this is the first time I'm receiving an RH positive blood, I will not die today because I've never been exposed to it. So right now I don't have antibodies against the RH factor yet. However, after that initial sensitization, we call that so I'm already sensitized, meaning I've developed antibodies against it. The next time I receive that RH positive blood, then I will have a fatal reaction. However, on the test question, if the stem of the question did not specify that this is the first time that the patient is receiving RH positive blood, the assumption is the patient has been previously sensitized. All right? That is for testing purposes. Please look at the details. For instance, look at this. With platelet transfusions, what does this say?
Typing is not a prerequisite.
Okay, when you're infusing platelets. However, there's a big however here. If you're giving multiple platelet transfusions, then there might be anti-HLA antibodies now because now you've received platelets from several patient donors already. And some of them may cause the patient to develop anti-HLA. HLA is a human leukocyte antigen. So this is a protein on top of every cell in our body that is unique to us. Typically, it's not present on platelets. Okay, they are present on red blood cells, all other blood cells, but not on platelets. Okay, so if a patient has multiple transfusions, not just platelets, the patient, meaning they've had a history of multiple blood transfusions, this increases their likelihood for a reaction. So typically the doctor will pre-medicate them with Benadryl or even Tylenol, okay? Or sometimes they'll give them hydrocortisone, also a steroid, okay, to decrease the possibility of a reaction. These are your roles. So again, these are this is QSIN, so this is totally testable. So they'll assume that you're going to be busy. They need to know, can you delegate appropriately? So in general, what can you delegate again? Or what can you not delegate? Sorry. So what are 3 tasks or 3 responsibilities or sets of nursing actions that cannot be delegated? Absolutely.
Evaluation, assessment, and teaching.
Okay. So those are the 3. So assessment or education, okay, or teaching, evaluation, assessment. So here, that's why all of these are under the nursing responsibilities. Okay, we need again the minimum needle gauge is 20 or bigger. We double check the second person again that can check it is another licensed nurse. So who is this other licensed nurse? What is the profession of this other licensed nurse?
RN.
An RN.
Like,
So only, sorry, Troy?
No, that was Kevin.
Kevin, what was that?
Oh no, forget it. Yeah.
Who else can check it with you? So you're the RN, you're the one giving the blood, you're the one going to hang the blood. Who can you call to, hey, can you double check this with me, please?
The charge nurse.
Okay, the charge nurse is usually an RN. Who else? Let's say there are no RNs available.
The doctor.
Doctor's not around.
Yeah. Okay. You saying who else can you check to confirm?
Who is
Doing?
another licensed nurse?
A phlebotomist.
That's not a licensed
Oh,
individual.
you're right.
LPN.
LPN.
An LPN is a licensed nurse, right?
Oh, okay.
Yeah, so they can check blood with you, but can they hang blood with you?
No.
No. So that's why it says here they can assist the RN with identifying the patient and checking the blood. So this is this second nurse right here. So the LPN can be that another licensed nurse. Clear?
Mhm.
All right. So what else does the nurse do? Okay, so adjust the infusion, watch them for signs of reactions, okay, and then monitor them for those reactions. What can the LPN do besides check the blood with the nurse, with the RN? They can monitor the transfusion rate. Again, this is for stable patients. Okay. What can your nursing assistant do?
Errands.
What else? Like what? What task they do?
Going to the blood bank and get the blood.
Right. You can send a nursing assistant to go get blood with you, get vital signs before the transfusion and after the first 15 minutes. Let's discuss this part briefly. So here, where is it? All right, here. So we have an order to transfuse. So you got the consent, you drew blood, You set up the tubing, you hang the saline, you prime the blood transfusion set with the saline, and now you need vital signs, right, before the transfusion. Okay, so it takes here, take the vital signs before the transfusion. Who can take this set of vital signs before the beginning of the transfusion? Let's say you're extremely busy.
UAP.
Right, so this is the vital signs mentioned here. Take the vital signs before the
The
transfusion.
nurse.
No, this is the before the beginning of the transfusion, meaning this is your base vital signs.
The LPN.
It can also be the LPN, but remember, we ask you for a delegation question. You should choose the minimum qualified personnel. That will show the best use of personnel, meaning between, let's say you have several tasks to delegate, right? Let's say you need to give somebody pain medication. The patient is stable, but they need a PO, pain medication. You can't get to it. And you also need a set of vital signs for this particular patient who is about to receive blood. You have an LPN and you have a nursing assistant. Who do you send to do what?
You're gonna send the nursing assistant to do the vital signs.
Exactly.
Oh yeah.
We use the nursing assistant for the vital signs because these vital signs are okay because these are the baseline. Nothing's happening to the patient yet. You haven't begun the transfusion yet. Is that clear? Because of course your LPN will be better off to go medicate your patient needing the opioid medication, right? So this set of vital signs right here can be delegated to a UAP, all right? So we have vital signs before we started the transfusion, and then finally, okay, now we have a phone call, blood banks calling, hey, I got your blood ready. Let's say the patient needs 2 units of blood. The order was transfuse 2 units of packed red blood cells. How many units do you obtain? You get the 2 bags?
I didn't hear. Can you repeat the question?
Okay,
How
so
many
the
units?
blood bank call.
Professor, can you repeat the question?
Yeah, okay, so
Because you're a little,
yeah, phone
the
rings.
signal is really bad for me.
Yeah, a phone rings, blood bank calls. Hey, your blood is ready. Come get it. How many units of blood do you get?
How many units does the patient need?
2 units is the order.
You get 2 units.
Okay, the answer is you take 1 unit at a time because unless it's an emergency, you can only transfuse 1 unit at a time. And you cannot keep the other bag of blood outside the blood bank because the temperature refrigerator there is different from what you have on the floor. So it has to be kept in the blood bank until you need it. Okay, so who do you send again to get that blood?
UAP.
The assistant personnel.
Okay, so you send your nursing assistant, hey, please go get it, please. All right, thank you. But first, before you go, take these vital signs for me. Okay, we got the vital signs. All right. So now the blood is on the floor. Nursing assistant gave it to you. And then who do you call again? Who can you call to double check the blood with you?
LPN.
LPN or an RN. Okay, so you have an RN, go get the LPN. All right, so we got it. We check it against the patient's ID and also the blood unit. Everything checked out. Very good. What if the patient goes to the CAT scan? CAT scan personnel came up, hey, I need to get your patient because there was a stat order for chest CT. I have to go now because otherwise I won't be able to do it. What do you do with the blood? Because the patient has to leave the floor. He'll be there for 1 to 1.5 hours.
You can't use it anymore.
So what do I do with the blood? Throw it in a pot of boiled water and make chocolate soup with it.
Maybe you send it
You
back.
send it back to the bank.
Very good. So if the blood is not used within 30 minutes, return it to the blood bank. All right, so now the patient, they canceled the order. They said, oh, my mistake. He wasn't supposed to go now. Sorry about that, my bad. Okay, so you proceed with the transfusion. We already have the vital signs before the transfusion taken by your CNA. Now the blood is infusing. Who should remain with the patient?
Nurse.
All right, the RN will remain with the patient for how long? For the entire transfusion?
15 minutes.
All right, you can't because you have other patients to go see. Okay, so but you
The first 15 minutes, when something, that's the likeliness of something occurring, and then you come back.
yeah, so the first 15 minutes, the RN must stay with the patient. Now, if the patient is fine after 15 minutes, then you need another set of vital signs, right?
Mm-hmm.
Who takes that set of vital signs?
You can ask the assistant personnel, the nurse assistant to do that, right?
Not this one. Okay, so
No.
we had a set of vital signs before, right? So before the transfusion, we had it. So this is the vital signs that CNA took.
During the transfusion.
Yeah. After the first 15, when the 15 minutes are up, you take another set, correct?
Yes.
That first 15 minutes of vital signs, the RN has to take that set of vital signs. Okay, the first 15. After the first 15 minutes, who do you send to take it now?
UAP.
The UAP can get that. Again, let me just clarify. The vital signs before you start the transfusion, the CNA can do that. The first 15 minutes wherein you stayed with the patient to watch them for a reaction and then to check the vital signs during that first 15 minutes will be the RN. After that first 15 minutes, then you can delegate that again to a UAP. Did we clarify that? Okay.
Yes, you did.
And how fast should that first 15 minutes run? 2 mLs per minute. Okay, so here is the, after the first 15 minutes, these are the vital signs that you can delegate, right? The first 15 minutes you have to take, and then after the first 15 minutes, you can delegate that one. So for packed red blood cells, the transfusion should take no more than 4 hours. Now that 4 hours though is counted from the time you took it from the blood bank, okay? Because that's the time that it came out of the ideal temperature. So it's now off storage, off refrigeration, so the blood will start to deteriorate beginning that time. So you need to make sure it finishes within 4 hours from the time you took it from the blood bank. Okay, again, it's out of refrigeration already, so it starts to die, plus it starts to get contaminated. So we can't put it in the refrigerator in our unit, not just because it's nasty, but I mean they can deteriorate. Blood transfusion reactions. You have a list here. Most serious is the acute hemolytic reaction. This is rare now because this is caused by ABO incompatibility, unless you just you're just grossly negligent and stop that. But good thing is, as long as the other people are not negligent, they did their job, so you may go scot-free because of this, because the other personnel did their job, made sure the blood bank made sure that they are compatible. Okay, but of course, for professionals, we need to do our own checks as well. Right, so the prevention, this, of course, you check your blood component against the patients. How do you recognize it? So same thing, just like with the complications with our central lines earlier, you need to know what does it look like, what will the patient show, and what do you do? For all of these, we always stop the transfusion. If you look at the rest of the table under management, like here, febrile, for instance, you notice that they say here, do not restart. That's for hemolytic reaction. For mild allergic reaction, do not restart. Anaphylactic reaction, do not restart, period. Circulatory overload, this one is preventable. Okay, so all you do here, this doesn't say stop the transfusion, but adjust the flow rate. Sepsis, the same thing. This is, of course, you just well, this is serious, so of course you can't restart. Massive blood transfusion reaction. Okay, we'll discuss those. So generally speaking, you stop the transfusion if any of these reactions occur. However, not all of them are life-threatening. One is acute hemolytic reaction. This one does not say restart, right? Meaning, can you restart the blood? No, you cannot continue with that because that caused the hemolytic reaction. So of course, that has to go back. This is now evidence. So this is like a crime. Okay, so you need to keep the blood bag for evidence. Okay, so we will deal with that later though. So you have other problems to take care of. Patient goes into shock because look at the patient's reaction here. Patient goes into acute kidney injury, shock, cardiac arrest. So you have to deal with that first. So these are what you do. Okay. However, of course, this is a critical patient, so you're already called rapid response at this point. For febrile reaction, this is not really serious. In fact, it's the most common, especially if the patient has had previous blood transfusions. Here, sensitization to donors, meaning they've had more than one transfusion in the past. So the doctor would just tell you, okay, of course you stop the transfusion, right? You call the doctor, he'll say, okay, give Tylenol. And then you can restart. Okay, because it says here, do not restart unless the doctor orders it. So typically what will happen is you call them because it's not a really rapid rise. I mean, it's only 1 degree. So let's say your baseline was 98, patient goes 99, call the doctor, he says, okay, give Tylenol, continue the transfusion. Okay, so that's what it means here. Prevention, if the patient already has a history of multiple transfusions, then you just, the doctors should know that and just order leukocyte reduced red blood cells, or we call them washed RBCs. Washed, meaning we remove the white blood cells, as many white blood cells as we can. Or give pre-medication. Okay, so 30 minutes before the transfusion, give them Tylenol and Benadryl. Allergic reaction, same thing. So similar to the febrile, look at the prevention. Okay, and then same thing. If it's a mild reaction, flushing, itching, but no respiratory symptoms, they're not short of breath, Then you stop, call the doctor. He'll order to, okay, give Benadryl or a shot of Medrol, and then you may restart, okay, if the doctor orders so. Anaphylactic, this is serious, so you have to treat the patient first because they'll die, okay, so from shock. CPR if needed. All right. And of course, do not restart the transfusion because obviously they reacted to the blood. So something is there that you can't continue with it. Circulatory overload. This usually occurs in either elderly patients or people with heart or kidney disease because these are the two organs that regulate fluid and electrolyte. So you should know this already. Patient has history of cardiac or kidney disease, so you should adjust the rate of transfusion. So you should use the maximum 4 hours in order to transfuse it. Or with doctor consultation, they'll divide the units into smaller amounts. Please read the rest. Let me just discuss this one. Have I discussed this one before? Seems like I did. Yes, no? Massive blood transfusion.
I think you did 2 weeks ago. I think you did.
Okay, so you still remember what causes the citrate toxicity again? Hey guys, still live?
Yeah, you said what causes citrate toxicity?
Yeah, what causes this?
Isn't it low potassium? No, low calcium.
Well, that's gonna cause hypocalcemia. But why would the patient go into citrate toxicity? Because citrate is used as a preservative. Yeah. Yeah, that's why the blood doesn't deteriorate while it's in storage. We put citrate in there so it doesn't clot, it doesn't deteriorate as fast. So it's like a preservative. But because we received citrate when we receive transfusion because there's citrate in the bag, then it will cause hypocalcemia now because now calcium and citrate are naturally attracted to each other, so they will hook up. Citrate binds the calcium, becomes calcium citrate, and they go straight into the bone. So the patient goes into hypocalcemia. And what are the signs and symptoms of hypocalcemia? So you guys already discussed that in the fluid and electrolyte chapter. And finally, hyperkalemia. These are the signs and symptoms. Hyperkalemia is because the blood continues to die during storage. So dead cells spill potassium when they die. So there will be a lot of potassium inside the blood bag. So this can occur if the patient receives multiple blood transfusion in a single day. Questions? And of course, these two problems will be dealt with separately. This one, hypocalcemia, then we give 10% calcium gluconate. And for hyperkalemia, what are the interventions again for hyperkalemia in the fluid and electrolyte chapter?
Diuretics.
One is diuretics. What else? So diuretics will eliminate potassium. What else?
You can give insulin.
Insulin with dextrose. Okay? Insulin is incomplete.
Yeah, with dextrose.
It has to be regular insulin IV with dextrose. Okay. So that will only shift the potassium though. Remember that intervention will not eliminate potassium. but we'll shift it really fast. So it will be the fastest intervention. Okay. Um, but remember, this patient may have severe hyperkalemia. So what is the which order will you carry out first? A, place the patient in a cardiac monitor. B, administer IV insulin with dextrose. C, give sodium polystyrene. And then 4, give furosemide IV. So which order will you carry out first?
The insulin and the fluids,
Insulin with dextrose.
the dextrose.
Dextrose.
B is place the patient on cardiac monitor,
Cardiac monitor, right?
especially if the hyperkalemia is severe. Severe meaning it's over 6.8, 7 or more. Reason is there's no intervention that will drop the potassium fast enough. The patient may go into cardiac arrest before your intervention, your pharmacologic interventions kick in. So you have to monitor the patient's cardiac status first. That way, if they develop cardiac dysrhythmias, then you can call rapid response. Any questions, guys?
No. What chapter is this, Professor?
This is 30.
Chapter 30. Okay, I understand.
The IV access device was chapter 16. This one, the procedure and the reactions, is chapter 30.
30. That's hematological problems, right?
Yes.